Good afternoon, everybody, and welcome to this Ortho TV original series on osteoporosis. We have today with us Dr. Manoj Chadda. He's a well-known endocrinologist with special interest in osteoporosis. He works at PD Hinduja Hospital in Mumbai and also has his own clinic, Hope and Care Center in Navi Mumbai in Vashi. We also have with us today Dr. Rajesh Gandhi, who is an eminent orthopedic surgeon, and Dr. Vikas Agashe, who is also having great interest in osteoporosis and its management. So, welcome to our speaker and our panelist, and over to Manoj sir for the further proceedings. Over to you, sir.
Thank you, Ashok. And I think, yeah, today is a special day because Dr. Vikas Agashe is with us on the panel. And I would like to remind him of the time 20 years ago when I joined Hinduja Hospital. And he had held my hand and got me into the group of orthopedic surgeons, and we had started dealing with osteoporosis. And I think that Durgavati Devi, our first patient, still
Yes.
following up with us.
Right,
Yeah.
right.
It's always a pleasure to have Dr. Agashe with the team. You know, we've been working as a team for quite some time now. We've had the first session on the general points on osteoporosis, and last time we had some discussion on calcium and vitamin D in terms of management of osteoporosis. We should not forget the importance of fall prevention because most osteoporotic fractures occur after a fall. So that's why neurological examination, muscle building, proper protein in the diet, these are very important parts of treatment of osteoporosis. Last time, I think when we finished, there were some unanswered questions. We had some doubts about the regimens to be used for vitamin D supplemented. So I'm going to spend just a few minutes to show you some slides on what are the options that we have. Yeah, I like to show you this slide to remind you that please get up. Osteoporosis is a serious problem and we need to get our head out of the ground. Okay, so I think what is most popular today in practice is this once weekly dose for 6 to 8 weeks and then follow it up with a maintenance dose, either a daily dose, a monthly dose, or a 6 monthly dose. But the important part is to have a maintenance dose. Now, see, this regime is probably very popular because it's easy to prescribe and you can't go very wrong. Sometimes they may be a little extra, but it's pretty safe. And treatment with higher dose may be needed in obese people, people with malabsorption syndrome, or on certain drugs like anticonvulsants and anti-tuberculosis therapy. So I was telling you about the maintenance part, and this is a study from All India Institute of Medical Sciences, Delhi. So the once weekly dose for 6 to 8 weeks, the end of 2 months, most patients did reach the level of sufficiency, which is about 30 nanogram per ml, or you multiply that by 2.5, it gives you 75 nanomoles. It's not millimoles, it's nanomoles per liter. And if you don't do anything after that, within 1 year, practically all of your patients come back to baseline values. So unless there is a method of having fortified foodstuff, fortified milk, otherwise our diet does not contain vitamin D and the importance of giving maintenance therapy comes up. So I repeat, you give 1500 to 2000 units a day, or you can give 60,000 a month or 300,000 in 6 months. All are good. The second option is to just start with 60,000 per month. So this is a study from SGPGI Lucknow, where the two set of patients, one is the control which did not receive any treatment, and the other was receiving 60K per month. So by the end of 3 months, there was a big difference between the control group and the treated group. And the ethics committee felt that it was not fair to continue the control group without vitamin D. So they were started also on 60K. And you find that within another 3 months to 4 months, they do reach acceptable values, which is again about 30 nanogram per ml. Whereas the one which was receiving 60K did well. And once the dose was doubled, they sort of started going up more than what was necessary. So again, confirming that 60K per month was a reasonably safe dose. Then there are others who feel that why should we give a mega dose, and let's just look at a daily supplementary dose. So this was a small study involving group 1, which is only calcium, the 500 milligrams of calcium. Group B was 500 milligrams of calcium with 500 units of vitamin D every day. And group C was 500 milligrams of calcium with 1000 units of vitamin D every day. So you can see that's the baseline, and that's the 3-month vitamin D level. There was hardly any difference when 500 units were given of vitamin D per day. But when the replacement was 1000 units, it did reach a level of near normal. So last time I did say that the normal levels are from 30 nanogram per ml. But when you look at population studies, then anything above 20 is also taken as normal. So you do get a decent level in about 3 months' time. But probably in our setup where vitamin D deficiency is so rampant, it makes more sense to start with a higher dose and then go on to this daily supplementary dose. And this question that always comes up when we discuss in orthopedic meetings is why not give parenteral dose? So this was a smaller study, 300,000 units intramuscular single dose versus the weekly dose of vitamin D. This was 5 weeks, so that the dose given in both the groups was 300,000. And in comparison, at the end of 6 weeks, you can see whether you gave intramuscular single shot or you gave a weekly dose. At the end of 3 months, the levels were comparable. So someone would argue that I may like to give a 300,000 single dose under supervision, which is what we used to do in the early 80s as interns. Everyone coming to our OPD at KEM hospital, we used to break one ampule. It was not given intramuscularly, we were giving orally, but which is equally effective. And as I mentioned last time, one of our studies from Nair Hospital, we actually showed that the ampule given orally was better in terms of the levels achieved at the end of 2 months. So that's something very interesting. So to further take up this discussion on this oral versus intramuscular administration, so when you give an intramuscular injection, you know that there's going to be 100% adherence. But with this oily injection, besides the pain that is severe with this injection, there can be unpredictable bioavailability. It tends to get deposited in the muscle and it forms a granuloma occasionally. The release from that depot may be very slow. So as compared to that oral administration, this intramuscular injection may actually be slower in terms of correcting the deficiency. And then you need a doctor or a trained nurse to give this painful injection. So that is why I think all over now, we recommend that as far as possible, it should be an oral administration. And intramuscular injection should be sort of recommended only in very difficult situations or where the absorption is an issue. So as we've been doing in the past, I'll take a break for a minute or two if there are any issues or any questions with this part of the talk. As Dr. Agash had once told me that the attention span is less than 8 minutes, so you should not talk for more than that at any time.
I think you have covered almost everything, and you have clarified how the regime should be. There is no doubt in my mind, at least.
Okay, yeah, I thought we discussed it last time. Yeah, but I just wanted to show these 3-4 studies to sort of convince the lot.
Sure.
Agash, sir, any?
Go ahead with the other next talk.
Yeah. And we don't need to keep monitoring vitamin D again and again if you're using one of these standard regimes, because the chances of toxicity are very less.
Sorry, one question.
Yes.
The role of active forms of vitamin D. Because see, most of the medicines available today have active form either 1-alpha or calcitriol. So
Okay.
when do you use it? How long do you use it? Advantages and disadvantages.
Yeah. So last time I did.
Achha, you have already covered.
No, I criticized that, but I love to talk about that because you should not use it. The use of activated D3 should be either with nephrologists who are dealing with kidney disease or with hepatologists who are dealing with liver disease, where the hydroxylation takes place. In practice, you may say that I want quick results, so I want to use the active D3. But as I mentioned, in severe vitamin D deficiency, the 25 hydroxylation is so fast that instead of 3 weeks, it takes about a day or two. So for all practical purposes, there's no justification for use of active D3 in any of our routine practice. You want to argue that, no, I still feel, then probably for 3 weeks, you can use it and then stop.
It is said that the renal conversion of 25 to 125 is not very good in elderly population.
Absolutely. So that is another subset where cautiously a small dose, say 0.25 micrograms, can be prescribed to the elderly patients. But I would prefer that to be a separate prescription and not with the calcium.
Okay.
So is it generalized for all the elders or people with a compromised renal function?
No, after 65, actually one hydroxylation starts going down. So it's not that it doesn't happen, but it is less than what it would happen when you were 30 and 40. Yeah, so that's a valid point. Every 65-year-old plus does not need the active D3. But if there's some underlying problem or the patient is symptomatic, I wouldn't hesitate in giving the calcitriol capsule 0.25 micrograms separately.
So overall, the epidemic of these active forms of vitamin D are not very good as far as the general health of population is concerned.
Exactly. So it's more driven by economics than science, and it is the commonest cause of vitamin D toxicity. You could give, if you remember from good old days, when you were a student or a registrar, 6 lakhs unit intramuscularly once a week for 6 weeks.
6 weeks.
But rarely would you see vitamin D toxicity. Nowadays, it is left, right, and central because of this active D3.
So is it that we conclude that if we have given active form of vitamin D3, it suppresses the hydroxylation, or it is to bypass the hydroxylation?
So you give active D3 when the hydroxylation is defective in the patient, but when you're giving it to the normal person, you're not suppressing their hydroxylation. It's just that you're increasing the absorption of calcium from the gut. So that is a 125 hydroxy D dependent mechanism. More 125 hydroxy D will be more calcium will get absorbed.
Thank you.
So chances of hypercalcemia would be more.
So vitamin D toxicity is hypercalcemia.
Hypercalcemia would be more.
So by itself, vitamin D is not going to hurt you or the patient.
Correct.
But vitamin D toxicity leads to hypercalcemia, which leads to the classic presentation of GI disturbances, altered sensorium, coma.
So in short, if your vitamin D levels are more than 100, which is considered to be toxic levels, but if the calcium is within normal limits, you are not worried.
There is no panic. If you get a report of 100 or 200, patient is sitting in your clinic, you just tell them, cut down on your milk products, or for a few days avoid it, take more salt and water, and the salt will pull the calcium out of the body. Okay. Now, so, when we define osteoporosis, etc., one of the clear things that is mentioned is that a fragility fracture is equal to osteoporosis. Today, if you were to talk to a physician or a cardiologist and tell them, oh, there is a patient with myocardial infarction, then it is very well understood that by the time the patient leaves the hospital, he's going to be on a beta blocker and one ACE inhibitor and a statin. This is a standard prescription. No one will ask you what is the blood pressure. No one will ask you what is the cholesterol. It is just a part of the post-myocardial infarction prescription. Now, this is a study from Canada, and we've done something similar. Dr. Balakrishnan at Hinduja Hospital had also done a survey that how many of our fragility fracture patients actually get treatment for osteoporosis when they leave the hospital. And this Canadian study talks about 15%. And unfortunately, at that time when Balki had done this study, our numbers were also equally dismal. Hopefully, with time, we have improved. We've not done any survey recently. But the important thing is, in spite of knowing very well that a fragility fracture is equal to osteoporosis, even in good centers, the number of patients who actually get proper treatment is very small. I mean, giving calcium, vitamin D for a couple of months is standard, but properly telling them about osteoporosis is not being done. And the course of action should be such that if there is a fracture, immediately the machinery should come into play. And that's what we'll talk next time when we talk about fracture liaison service. So I think the important part is we should now start thinking the way the cardiologists think or the physician think, that heart attack means beta blocker, statin, and a ACE inhibitor. So similarly, a fragility fracture means treatment for osteoporosis. The question that comes up in practice is, how do we decide about treating the patient? I mean, we discussed about the investigation. We said we'll do a bone density, but bone density may not be available in all the cities. It's more concentrated in the larger cities, in some larger centers. So we have to talk about looking at fracture risk. And if it's a low risk, 10% or below, then probably we need to advise them about the non-pharmacological measures, weight-bearing exercise, and fall prevention. If it's a high-risk patient or the patient has already had a fragility fracture, then there is no discussion, argument. You just need to choose what therapy you want to give and then go ahead and prescribe the therapy. The dilemma that comes up is the set of patients in between. Now, you see, in our country, the doctor prescribes, the patient takes the treatment, and the patient pays for the treatment. So there are no questions asked. But in setups where the insurance is paying for the treatment, then you have what is called as the cost benefit analysis, and you have to justify why you're giving your therapy. And that's where the dilemma comes, to treat or not to treat with pharmacological therapy. So here are some of the reasons why you would think of taking treatment or giving treatment for a patient who comes otherwise in the moderate risk category. So a vertebral fracture on the lateral spine X-ray or a wrist fracture in a patient who's more than 65, but the BMD is still less than 2.5. So it's still in the osteopenic region. So this is what, like we've been saying, a fragility fracture needs to be treated. The other reason is if there is a very big difference between the lumbar scores and the femoral score. So in the first lecture, I did mention that because of the pathophysiology, the estrogen deficiency leads to a predominant lumbar loss. And if the lumbar spine T-score is much, much less, that nearly 2 standard deviations less than the femoral score, then that becomes an indication for treatment. In addition, if there is secondary osteoporosis like hypogonadism, early menopause, primary hyperparathyroidism, hyperthyroidism, rheumatoid arthritis, glucocorticoids, aromatase inhibitor therapy for cancer patients. So these are again high-risk patients and should preferably be treated at an early stage. If the patient has a tendency to fall and has fallen more than 2 times in the past year, it again becomes an indication for starting treatment in moderate risk. And I think what is important is sometimes because of Dr. Google or some relative in the family, well-wisher or a well-wishing family doctor insists that this patient should be treated, then there is no argument. You have to give treatment to such patients. Should I halt for a minute if there is anything that comes to the mind?
Yeah, you mentioned about the ladies who have got osteoporosis. Menopause earlier than 45 years of age.
Yeah.
Now, says there are people who have undergone hysterectomies. Now, how long does it take after hysterectomy for the ovary function to go down? Because the ovaries are intact. They have not undergone oophorectomy.
No, so that's I think a very good point. So there is someone who has had a total hysterectomy, the uterus and the ovaries.
Yeah.
That is immediate menopause.
Yeah.
But even those who had only hysterectomy, it has been seen that within 2 years, their ovarian function declines to practically nil.
That's
So
because of the
you
target
have
tissue
to-
is no more there.
Yes. So 1.5 to 2 years down the line after hysterectomy, you can think that the menopause has set in. See, the unfortunate part is vitamin D deficiency, you correct with vitamin D, and B12 deficiency with B12, and calcium deficiency with calcium. But the estrogen deficiency which sets in at 38, 40, 45 is not treated with estrogen. You see, that's the sad part. Our gynecologists have got so scared with the old WHI study, which showed an increased risk of this breast cancer and uterine cancer with estrogen. They have not read the whole story. So early menopause still remains an indication, and I'm hopeful that in the next year or so, when the fresh data comes out with WHI, as it used to be called HRT, now it is called MHT, menopausal hormonal therapy, and hopefully this will come back, because at 40, 42, 45, you don't need to start giving anti-resorptives or bone formation agent. You need to give them what they are deficient. And safely till 50 years, they can be given estrogen or estrogen progesterone combination, depending on whether the uterus is out or the uterus is in. Anyway, I am also not a gynecologist, so I don't prescribe it, but I do advise my patients to talk to their gynecologist about using HRTs.
Have you used Reloxifene for the same?
Somehow, Reloxifene never became popular. The SERM category, although they are useful and have nearly the same effects on the bone as estrogen, two things. One is they do have, in the patient has these menopausal side effects, hot flushes. For that, you have to give estrogen. Reloxifene does not work. And Reloxifene has no effect at the hip. Its predominant effect, or the only effect, is on the lumbar spine. So it's a good replacement. The risk of cancer with Reloxifene is practically nil, but it never became a very popular drug.
But you do recommend that HRT should be given, or MRT, as you rightly put
MHT
it.
or
Yeah,
MRT
Yeah.
is an option, with the regular precaution. But again, I'm telling you, till the age of 50, there is no issue.
Okay. Thank you.
Sir, I have two questions from Ortho TV viewers.
Yeah.
So you mentioned about repeated use of glucocorticoids. So what does that exactly mean?
That's a very difficult question. If you've seen the FRAX score, there is no mention of how long. But I'll tell you, if you feel that your therapy, even 5 milligram a day of prednisolone, or 20 milligrams a day of hydrocortisone, or 0.5 milligram of dexamethasone, if you feel your therapy is going to go for more than 3 months, if you feel, it's not that 3 months are over, if you feel also at the beginning of your prescription, then you consider it as a glucocorticoid long-term use. So that's the recommendation. Don't wait for 6 months, because the maximum bone loss on glucocorticoids is in the first few months of therapy. So if you're going to wait for 3, 4, 6 months, probably you're missing the bus.
Are the doses little less than, say, of alendronate for prevention rather than treatment?
So, Dr. Agashe, when you go back to the mid to late 90s, when alendronate came into the market, there used to be a 10 milligram preparation and a 5 milligram preparation.
Correct.
So the preventive dose is out of the market. There is no role for using alendronate or any bisphosphonate to prevent osteoporosis.
Okay.
I will give you one situation in my slides later on, when I give you some cases on where you would think of using bisphosphonate as a preventive therapy. But for practical purposes, not routinely.
No, instead of 5, we have now 35, which can be taken for in a week's time. So that also you will not recommend.
No, it's not recommended. No, I will mean I'm just telling you from the guidelines. And
we have few questions on bisphosphonates also. I
Okay.
think we'll carry on
We'll-
when
we'll-
we come
we'll
to that
come to
point.
Correct. Okay.
Before
Yeah.
that, actually, there was one question which was unanswered last time,
Yeah.
and I had promised that I will ask it today.
What was
So
that?
there was this calcium anhydrous, calcium aspartate anhydrous, which is supposed to have viability of around 92%.
Yeah, about 100%.
Yeah.
So,
But you said that you should not give more than 500 milligram, and it is available in 1200 milligram.
no. So what I said was you should use the regular carbonate or citrate maleate or citrate in all patients. If they cannot tolerate or if they have a renal problem, then you need to go for an expensive preparation. And I also mentioned that most calciums are labeled with the amount of calcium which will reach the circulation. So calcium 250, calcium 500 may contain much more the salt, but what reaches the circulation is that. So I think most aspartates are 100 or 250. There's no 1200. I mean, I'll confirm it, but to my knowledge, orotate, organic calcium, AAA calcium, those are 100 to 250 only.
Okay.
Right?
Yes.
I'll check it up again. If you just send me a WhatsApp before the next meeting, I'll bring it up again.
Yes, sure, sir. Okay.
Yeah.
Okay, you can go ahead, sir.
Yeah. So the goals of therapy are very clear. I mean, there may be a patient, someone you know with the most terrible BMD reports that you've ever seen. But as long as she or he don't fracture, you're not bothered. So you have to prevent fracture as far as possible. And as we always say, if there has been one fragility fracture, please go aggressively to prevent the second one. And then obviously you want to increase the bone mass, and in addition, you need to relieve the symptoms. So that's where the surgical role comes in, and see that the patient remains mobile and functional. When we are deciding on therapy, now this osteoporosis is a very unique disease. Diabetes, hypertension, hypothyroidism, statin, cholesterol, these are treated for life. But when we talk in terms of osteoporosis, we always talk for a finite period. It's not that after 10 years or 20 years, you will correct the problem of bone loss and the patient will now start getting better. It's just that most therapies of osteoporosis are given for a finite period, because after a certain stage, we are worried about the adverse effect. So that is something which should be very clear to the prescribing doctor and to the patient. And that finite period should be completed. You know, I have seen people saying, "Abhi 3 mahine ke liye le lo, fir dekhenge, abhi 6 mahine ke liye le lo." So most osteoporosis therapies really start working after 6 months. In the first 6 months, we don't expect any fracture protection. And the real effect starts coming in after about 12 months of therapy or so. So teriparatide, we know it's for about 24 months. Still, I hope it increases in the near future. Bisphosphonates are variable. Alendronate is about 10 years. Zoledronic acid is 6 years. Risodronate is between 5 and 10 years. So when we say 5 years, 6 years, 10 years, what we are saying is that the safety has been proven for this period. The efficacy is always there, but then after a certain stage, the benefit and the disadvantage are at level, and beyond that, the disadvantage starts taking a precedence over the benefit, and that's why we get worried about using it for a longer period. For denosumab, the duration of freedom study was for 10 years, so that's why we say 10 years it can be safely used. Tomorrow, when more data comes in, it could be even 15 years. And the other concept, which I'll show you 1 or 2 slides down the line, is this drug holiday business. Again, when we are using a drug like teriparatide, that is to be used continuously for 24 months. When you use a drug like denosumab, it has to be used for the duration of prescription without a break, because there is no long-term memory with denosumab. But the bisphosphonates, there is a memory effect. We say that we stopped giving the drug, the action may go away. But we don't know how long bisphosphonate stays absorbed in the osteoclast, weeks, months, or even years. And that is why this concept of drug holiday came in for the bisphosphonates alone. In addition, I did mention a little about bone markers. So if you have a good lab near you, You can use the resorption markers to know how effective the anti-resorptive drug is, or formation markers to know how effective the anabolic drug is. These are the options that are available to us. Bisphosphonates, HRT, like I don't think orthopedic surgeons would be interested in. Denosumab is the new kid. Last couple of years, you've been using it now. The anabolic agent, today it is teriparatide. I think within the next few months, romosozumab will be also coming in. So next time I will show a couple of slides on romosozumab and how it is different from teriparatide. Cathepsin K inhibitors is a fantastic oral once a week drug, but because of the increased risk of stroke after development and wonderful efficacy, the BMD going up to nearly 9 to 10%, it is not going to come into the market. It has been withdrawn by the company. And stem cell therapies are there everywhere to see. So we will look, maybe hope in the near future something will come in. The question that also comes in after the duration of the therapy is your patient failing on treatment? So there's been a very interesting collection of data in terms of compliance and adherence to therapy. And it has been seen that any chronic therapy, where otherwise the patient is doing well, there are really no symptoms, nearly 50% patients stop taking treatment after 1 year. And that's one of the reasons, even if you give the best therapy with the best intentions, you may have a patient failing on treatment or fracturing when your prescription is still on. This patient may not be taking his treatment, and that has to be ensured. And that's where, again, when we talk next time on FLS, the importance of having a connect with the patient regularly so that they're taking the treatment continuously. Technically, treatment failure is considered after 1 year on the treatment. So that said, 6 months, don't expect anything. Patient fractures, unfortunately, don't even look at it. But at the end of 1 year, if there has been a decrease in bone density, that means more than the least significant change of about 4%, or if the patient has 2 or more fragility fractures on treatment, then you say that this treatment is not working and you need to go on to the next option that you have in your kitty. In addition, before writing off a drug and you have checked the compliance, you should also see that any other new medications have been given which would worsen the bone density, or if there are any new comorbidities. So one of the things which I have been talking very often on whatever media that I've got is diabetes and bone disease. So diabetic patients are more prone to osteoporosis. And as I'll show you in one case, a diabetic with a BMD, which is less, which is like even is more than 2.5, minus 2.5, is still prone to fractures. So between two patients, a diabetic and a non-diabetic, you need to actually look at -1 extra in a diabetic patient. So if there's a minus 2.5 non-diabetic osteoporosis, then for a diabetic osteoporosis, the BMD may be more towards -1.5. That's something which probably we've been trying to get more physicians interested in. But if you keep that also in mind, that'll be nice. Anything on the adherence part, or should I go on to the adverse effect?
I think you can go ahead and then we'll discuss it at the end.
Okay, fine. So, I'm not discussing each drug in terms of adverse effect, but in terms of bisphosphonate, you need to remember that when you prescribe it, in the next 3 to 4 weeks, you must check for calcium, because any bisphosphonate, denosumab, can cause severe hypocalcemia in a borderline calcium deficient patient. And it's very important that when you're writing bisphosphonates, you first make them vitamin D replete. If you don't give vitamin D to patients, you're writing bisphosphonates, they may develop osteomalacia over the osteoporosis. So correct the vitamin D, check the calcium in 3 weeks or so. We are all familiar with the GI symptoms that can happen, especially with the oral bisphosphonates. And there are some patients who have been prescribed oral bisphosphonates but had to stop it because they could not just tolerate it, even if it's once a week or once a month. Musculoskeletal pain. I have seen one of my colleagues complaining of musculoskeletal pain with oral alendronate. Forget the longer acting variants of bisphosphonates. Even with alendronate, she had terrible pain and she was cursing me for the next 3 to 4 weeks. So some of these patients can get severe musculoskeletal pain and probably an idiosyncratic reaction or vitamin D deficiency. The rare osteonecrosis of jaw and the atypical fracture is what I think is a nightmare for the dentist and the orthopedic surgeon. And I've got a couple of slides to look at that. Uh, Patients who have a declining GFR, the serum creatine has started going up, we will not use bisphosphonates. And probably that's one of the clear-cut indications for using denosumab. A GFR which has gone below 45 and definitely below 30, you should not use a bisphosphonate. Atrial fibrillation was reported with zoledronic acid in a little higher number of patients in the Horizon trial, but in practice and in the data which has been collected in the real world, this has not been proven. So it's worth doing an ECG in your elderly patients if you're writing zoledronic acid, but you don't need to scare anyone. Raloxifene, like I said, did not become very popular, and it has the same thromboembolism problems that you would see with estrogen. There was a slight increase of risk of stroke. There is no improvement if you have the postmenopausal flushes and hot flushes and reactions. You have to use estrogen in that situation. In terms of teriparatide, it's a relatively safe drug, except for the fact that you need to give it every day, day after day for about 2 years. So teriparatide is a good drug. Here, you need to keep the orthostatic hypotension in the elderly. You're worried. Osteosarcoma, I think, is more of historical interest. Although recently, I read in one of the publications that there have been 2 reported cases of osteosarcoma with teriparatide. I don't know how to react to that because in a couple of million prescriptions, if you've had 2 cases, then we don't know, it might have been just a by chance occurrence. What I'm more worried about teriparatide is the calcium going up. Now, there are 2 situations. One is you're giving teriparatide, there may be a slight increase in calcium, and in the next 8 to 10 hours, the calcium comes back to normal. So if you have given the dose at night and you check your patient's serum calcium in the morning, you would expect it to be normal. Sometimes it tends to be 10.5 and above. There are 2 things you can do: reduce the vitamin D dose that this patient is getting, reduce the calcium supplement that this patient is getting, and check the urinary calcium. 24-hour urinary calcium should be less than 4 milligram per kilogram body weight per day. So you need to do a 24-hour urinary collection. It's not very common. It's a rare occurrence, but it's worth knowing about it, that sometimes serum calcium goes up. What is scary and what we have seen a couple of patients is in the enthusiasm of writing teriparatide, the fact that this patient was hypercalcemic to begin with and had primary hyperparathyroidism was missed out. So please, before you write teriparatide, check for serum calcium, preferably check for serum PTH. The PTH may be elevated due to primary hyperparathyroidism, but 9 out of 10 times it is elevated because of secondary hyperparathyroidism. Correct the vitamin D deficiency, bring the PTH back to normal, and then think of writing teriparatide. So that's the important part in terms of analyzing the adverse effects of these drugs. I'll just show you some slides on the atypical fracture and the osteonecrosis of the jaw, and then we'll take a little break to answer questions. So these started coming up, I think, nearly 15, 20 years ago. Very occasional mentions in the poster presentation, low energy. So these are not the intertrochanteric fractures that you're used to seeing in your practice. These were, the diaphyseal fractures. And, the relationship of the bisphosphonates. So specifically, it started with alendronate, but it's been seen with other bisphosphonates. It has now been seen with denosumab also. So it can happen with any anti-resorptive therapy. And that's how people started saying. There was a period in the US where the prescription of anti-resorptives went down drastically because people were scared about the side effect of the drug before the effect of the drug was looked at. So the important part is that these atypical or unusual fractures do not start occurring within the first few months or the first few years of therapy. It's been seen with alendronate after 5 years of therapy. It can happen rarely in the first 1 or 2 years, but mostly it's after 5 years. And the same thing with zoledronic acid it's been seen after 3 years generally. So the second half of the treatment, you need to be careful about these unusual side effects. And the last Endocrine Society conference in India, we had a speaker from Australia who gave us such a lovely insight into these atypical fractures, and he was talking about genetics and things like that. So it's not just that you give bisphosphonate. After all, if you give bisphosphonate to 1,000 people, how many of them actually get atypical fracture? I'll give you the numbers down the line, but it's not that you see it left, right, and center. Similarly, osteonecrosis of the jaw, a rare complication. It's less than 100,000, 1 in 100,000 after a substantial use of bisphosphonate. You're not going to get in the first few weeks or the first few months. And it's not so common. So a routine dental examination also is not recommended before you write a bisphosphonate. Yeah, standard dental hygiene, you can talk to your patient, but you don't need to send them to a dentist. What is important is that if the patient has been on more than 3 years of therapy, then probably you need to send this patient to the, very careful when they need dental procedures. So the bone exposure is what is known as the osteonecrosis jaw, which is not healed for 8 weeks. And that's a extraoral fistula. So look at this slide. Osteonecrosis commonly, or the predisposing factors, are advanced age, chronic inactivity, corticosteroids being used continuously, diabetes, hemodialysis patients, hyperlipidemia, thrombophilic disorders, infection. All in all, these are sick patients. So a otherwise healthy patient on treatment with anti-resorptives is unlikely to get osteonecrosis. On the other hand, cancer patients, steroid-dependent patients, poorly controlled diabetics, these are the ones you would really get worried about osteonecrosis. And this is the interesting slide that I like to discuss. This is from Canadian database really, but about 8.4 per 100,000 person die per year. About 1.8 get murdered per 100,000 person per year. And osteonecrosis of the jaw is less than 1 per 100,000 patients per year. And the atypical fracture on treatment less than 2 years is 2 per 100,000. But if it is 8 to 10 years, then it is about 100 per 100,000. So that is the time. So after 5 years, you need to get a little cautious, and less than 5 years, it's nothing that you really need to, and you can't do much about it. So be aware of it, be proactive in terms of when the patient gets pain in the thigh, you need to get a MRI done quickly. Sometimes you can catch it in the prodrome, and at that time just fix it and prevent the patient from fracturing. Yeah, so we're going to take a little halt here, and in terms of the complications that I've discussed, if you have comments. Sorry.
My question is, most of our orthopedic journals, especially papers coming out from Sweden, where they have a phenomenal fracture data and exceptionally good follow-up. Most of those papers say that about 3 to 4 or maximum 5 years of bisphosphonate should be given. The incidence really starts going up after 3 years. So generally, unless it is strongly indicated, bisphosphonate should not be given beyond 3 years as per the Swedish data. Another important paper that they have is there are two different groups as regards location is concerned. We always keep saying subtrochanteric fracture. They generally occur at a little earlier age, and as the age advances, there is another peak of midshaft fracture. So elderly people often get midshaft fracture, and youngish patients get subtrochanteric fracture. I mean, this is just to keep people informed that even an atypical fracture can occur at a midshaft level. And as regards the duration, I would like your inputs, because most of the endocrinologists believe what you are saying. And most of the orthopedic surgeons keep saying that 3 to 5 years is maximum.
Okay, so alendronate 5 years is pretty safe, and because it's a long-term acting drug, it gets deposited in the osteoclast. There is this issue of drug holiday. Probably, if your patient has gone, the BMD has improved above minus 2.5, you can keep your patient under observation without any medication and follow them up with bone markers every 6 months. So that is a very justified thing. With zoledronic acid, we used to say once a year for 3 years, take a call whether they want to give another 3 years. But of late, data has been coming in that zoledronic acid, you can give it once in 18 months instead of once in 12 months. And there have been other people who have looked at bone markers, not fracture data, but bone markers and bone density. And up to 24 months also, the resorption markers don't increase. So effectively, what I'm trying to say is that what we have been traditionally taught that every year you need to give zoledronic acid, you can make it 18 months safely. And if you have a good lab with you who will tell you bone markers, then it can even go up to 24 months.
I have one question on this.
Yeah.
Zoledronic acid, some orthopedic surgeons are using twice in a year for osteonecrosis of the head of the femur.
Yeah.
Now, I have failed to understand the rationale. Even for the osteogenesis imperfecta, they are using it twice in a year. Even for the slip capital femoral epiphysis, we have seen patients who have been treated by others who have been giving. Now, is there any rationale in giving it twice in a year?
So the only people who use zoledronic acid more than what is recommended is the oncologist. They use it even once a month. Because
that
they
is for
are
the
using it for
different reason. Yes.
metastasis, exactly.
Yeah, yeah.
Otherwise, osteogenesis imperfecta, actually the right drug is to use pamidronate and not zoledronic acid,
Yeah.
because they are children. But we have used it again 12 to 18 months. I have not seen it being used at Hinduja less than 1 year. I'm not sure about the other things. I know about your avascular necrosis. There are publications. I think even from Hinduja we have some recommendation of using alendronate. But I'm not, read much about it in the, the regular scientific press. And I think if there is somebody in the panel, let's say Dr. Agashe wants to make a comment on that.
Yeah, I would like Dr. Agashe to comment on this.
Yeah, all the original studies were done on 10 milligrams of bisphosphonate or alendronate rather, once a day. And that was for 3 years. And that study continued till about 2010.
Yeah.
Of late, after 2010, not off late, after 2010, Dr. Agarwala has been using zoledronic acid once a year plus 35 milligrams of alendronate twice a week, and he claims that the action starts much earlier. But otherwise, from whatever his conclusions are, the final result is almost similar.
Yeah.
So
I don't think this business about starting earlier and all that really has been ever shown. And it doesn't make sense to combine two drugs from the same family. I'll show you in the end a combination of anti-resorptive and bone formation, but so they are different families with different mechanism of action.
But I wanted to ask you, do you think that these alendronate risedronates given after fractures, do they actually interfere with fracture healing, especially in the acute stage?
I think that has been settled now. It does not interfere with the fracture healing.
So it can be started as soon as immediately?
Yes.
Even before discharging the patient?
Yeah. So what they say is ideally you should wait for 2 weeks, because otherwise the drug will get concentrated in the fracture site and the rest of your skeleton will not get it. This is specifically with zoledronic acid.
Okay.
But if you're going to start an oral drug, which you will give every week after week after week, so whether you started immediately 1 week or 2 weeks down the line doesn't make a difference. But for sure, it does not interfere with fracture healing. Although, logically you may say that it's an anti-resorptive for fracture healing and bone formation, you need that sort of thing, but it's not been shown that it does affect the bone healing.
Dr. Agashe, I need your opinion on the slip capital femoral epiphysis. Usage of bisphosphonates in slip capital femoral epiphysis.
I have not come across any paper. I have never used, of course, but I don't think I have come across any paper related to this. And
But
just
pediatric orthopedic surgeons are using them.
one more addition to the combination of this, Dr. Agarwala feels that the action starts much earlier with the combination. I have not used it, but he has been regularly using it, and he feels that the pain relief in AVN is much earlier with the combination.
Yeah, thank you, sir.
So,
So
we
we'll go
have
ahead.
to wait and watch till his results are published and his results are he analyzes everything and then publishes.
Yeah, so that we'll see then. So I've been talking about drug holidays, especially with the long-acting bisphosphonates. And the important thing
Can I just interrupt? Uh, Rajesh,
Yes, sir.
have you come across people using alendronate for slipped capital epiphysis, and
Yes, sir.
are there any
Yes.
papers?
I don't know the papers, but it was used in a patient whom I knew.
Achha.
I was treating and they went for a second opinion. So that time it was given. So that's the reason I am asking this question.
No, I have
So
not seen.
I asked the consultant, is known to me. So he told that we are giving for whatever it is worth, like it is similar to what we give in adults for avascular necrosis. We are expecting a very high chance of avascular necrosis in this
Yeah.
particular patient. So we would like to use it. Fair enough.
I guess the etiology of slip cametal epiphysis is not clear. We see it in endocrine disorders like, hypogonadism, some syndromic disorders. Yeah, but frankly, there is no clear-cut guideline or indication for using these antiresorptors.
Yeah, even I tried to find out. I couldn't find any papers on that, sir.
Okay.
I mean, rather than giving pharmacological therapy, surgical stabilization, stroke fixation, stabilization, as well as in severe cases, maybe safe surgical dislocation, reduction and fixation would be
Yeah.
possibly better.
Good
Yeah.
idea.
It was already done, sir. And
Achha,
immediately
okay.
he went for a second opinion after
Okay.
the surgery. So
Okay.
another person advised this. So I was quite surprised actually. I have never used it, not heard it being used, not any conference they had mentioned it. So I just talked to him. He told that this is a similar pathology, so we are giving it. Fair enough.
Fair.
And since he has
Uh,
gone, patient had gone for a second opinion, I didn't want to disturb much.
So if I can add to it, sir, Agash sir.
Yeah, tell me.
So there are clinical trials are undergoing in use of adolescent from 10 years to 18 years, use of palmidronate for AVN, not specifically mentioning SCFE, but SCFE is one of the, they have included SCFE in that AVN group.
Okay.
So the trial is ongoing and results are yet to be out, but the trial is ongoing. And I also know a few surgeons in US who are using this in children, but again, not published data.
Is palmidronate available in India? Because as I know, it was not.
It's very difficult to get palmidronate.
Yeah.
I think one of our colleagues from Mira Road said that he had managed to get it, but it's not really freely available.
This trial is going on hospital for sick children, US.
Okay.
Yeah.
But so the cause could be different, like so many malignancies produce AVN, and
Absolutely.
So whenever there is AVN, giving alendronate or palmidronate is worthwhile. For prevention of AVN in surgically stabilized slip capital femoral epiphysis, I think it's possibly, in my opinion, a little more than needed. Possibly.
I thought it was an overkill, but still wanted to be. I talked as I told. Anyways, fair enough, sir.
Okay, so let's have a little discussion on this patient that we have here. This is a garden variety case. No anything hidden agenda. 64-year female, 14 years postmenopausal, recent onset backache, vitamin D 16, P-score of -2.9 and a Z-score of -1.6.
Any treatment taken before this?
No, she's come for the first time. So do you want me to go on giving?
No, my question, which I keep asking everybody again and again
Yeah.
is a part of this would be osteomalacia, low T score,
Yeah. So
isn't it?
that's why I put this thing and backache. So please remember, unless you fracture, osteoporosis is silent. So when someone is coming to you with a backache and you don't diagnose osteoporosis because of that. So this patient, like Dr. Agash has said, could be more of osteomalacia on a setting of osteopenia, and that's why the T score has gone to minus 2.9. But I would treat the vitamin D, and whether we give bisphosphonate to this lady or denosumab to this lady could be a point for discussion. We'll just hold on to the discussion right now. We'll not go into that.
My question
Yeah.
is it worthwhile repeating T score after a few months once you have replenished vitamin D?
Okay. So in a normal setting, the answer is that you should not do a VMD before 18 months.
Agree.
But when you have osteomalacia as a differential diagnosis, when you have primary hyperparathyroidism as a differential diagnosis, when you have Cushing syndrome, glucocorticoids as a differential diagnosis, doing it within 6 months is permissible and a smart thing to do. You would see a difference. So instead of rushing into treatment right away, correct the vitamin D, some exercise, calcium, repeat it in 6 months and see what is happening. That's a perfectly justifiable decision to keep. Okay, so there is no prizes for guessing what you would do in this patient. Elderly male slipped in the bathroom, standard fracture, T score of minus 3.8 and Z of minus 2.4. I just made it a male patient so that it will be different everywhere you keep talking about females. But there was one large study from Delhi which actually said that hip fractures in the senile group are more common in males than females. The only possible flaw in that study could be it was a hospital based study. So, what he was trying to say is that more males reach the hospital than females. I mean, I don't know about other hospitals, but for example, at KEM hospital, the male wards were or male beds were much more than the female beds. Not that females were less likely to fall ill, but it's just that they were less likely to come to the hospital. I mean, that was a social problem. So anyway, so there we have a case where this has been a intertrochanteric fracture. You've done a great job. You've fixed it. Patient is going to go home now. So what are you going to advise to this patient?
Well, full bucket of osteoporosis treatment has to be given to them.
Yeah.
There's no doubt
So
about that.
you have all the options in front of you, and you have to decide whether you want to give him a bone forming agent, anabolic therapy, or you would like to give anti-resorptive. Now, up till recently, say about 2 years ago or 3 years ago, uh, the effect of teriparatide on the lumbar vertebrae was fantastic, and it was matching the zoledronic acid or the alendronate reduction in fractures. At the hip, it was supposed to be less than what you got with zoledronic acid or denosumab. But in the last 3 years now, data has come which says that it is as good. So if you believe that a bone formation agent at this time, when there is severe osteoporosis, a very serious fracture, the risk of mortality has also gone up, then probably using your best drug at that stage makes sense. So that's why I put this old slide. Yesterday night, I got a couple of studies. I sort of apologize. I could not make slides on it. But if someone is interested, I would be happy to share those references. Yeah, so these are standard. I just wanted to review that with the lumbar vertebrae, there's about 65% risk reduction, and non-vertebral fractures is about 50%. And with hip is about between 30 and 50. But now, like I said, the new references are talking that it is as good as zoledronic acid and denosumab. So probably in this elderly patient, my first preference would be to use teriparatide right away, and then follow it up with zoledronic acid. Or as I'm going to show you some slides, use teriparatide and denosumab from day one. I don't know how many of you have thought or heard or read about using both of them together from day one. Dr.
Sir,
Gandhi,
can I ask one question on this?
I thought you were saying you are using it.
Oh, no. You mentioned just before this particular slide that you would start the teriparatide in a patient straight away. He is a treatment naive patient. He has never taken any treatment. The fracture is the detection of osteoporosis.
Correct.
Now, is it recommended in a treatment naive patient also to start on teriparatide straight away?
Yeah, I mean, why? I mean, if you feel that this is a serious osteoporosis, then you can start straight away.
Okay.
Unless you are in Europe. Okay, so let me tell you, you can start in the US. The insurance will pay for it. For Europeans, they have to have a second fragility fracture before teriparatide prescription is honored by the insurance company. See, in our country, doesn't matter. You can write what you are the boss. It's only the idea of this discussion is to argue why not this, why not that. So I mean, my thing is that if you had asked me this question 6 months ago, I would have said let's use zoledronic acid or denosumab. But now with this new data that has come up, I think using teriparatide as the initial treatment so that you can have bone formation, improvement in density, and like some of the orthopedic surgeons said, it also improves fracture healing. So that is also being studied. It is not there in print, but I saw yesterday night while going through the references that there are now anecdotal mention of better bone healing. So although it's not a indication, it's not there in print, or what you say as the the standard company recommendation. There are now people who are using it.
Yeah, they call
Just
it as
to-
off the book recommendation.
Yeah, just to give you an input,
Yeah.
I was talking to a national manager of a pharma company. I said, Doctor, you will not believe 40% of teriparatide today in India is used for management of non-unions.
Yeah.
So that's
No, no.
possibly
So,
an overkill.
yeah, so non-union is
Overkill.
now you've gone beyond. I am talking of the first union.
Yes, but that is what has happened now.
Yeah.
That is what has happened.
So I don't know today, but about a decade ago, there was a survey. I mean, I can tell you, Eli Lilly had done a survey, and the 80% probably prescription of teriparatide was from the orthopedic surgeon. But unfortunately, that prescription lasted for an average of about 3 months. You see, so that is where the issue was, and probably what I just said, that it's an off-label use and still not proven, but it's something that people are working on.
Sir,
So this
in
is
this
the,
combination, I have a question
Yeah.
before we go ahead.
Yeah.
So, if as you told that 70 years old patients which comes with a fracture, you give both, that is the ideal treatment. I understand. But nowadays, people are living till 90. And denosumab can be given for 10 years, teriparatide 2 years. So instead of giving it total for 10 years, why don't we give it for 12 years? By first give teriparatide for 2 years and then give denosumab for the next 10 years. So at least patient is taking something or the other.
Okay, so can I answer that question
Yes,
after
sir.
4
Yes.
slides?
Okay, sir. Sure.
So this is the answer to your question. Patients, 100 postmenopausal women were divided into 3 groups: teriparatide, denosumab, and combination therapy. So is it really worth? That's what the study was. 20 microgram teriparatide daily, 60 milligram denosumab every 6 months, and both. And BMD was measured at 0, 3, 6, and 12 months. I found this very interesting. That's why, I mean, normally I've tried to keep out all studies from this talk, but this was very interesting. So, in terms of the percent, this is the teriparatide group, and this is the combination. At the anterior lumbar spine, there is no difference, no advantage of using the combination therapy. At the femoral neck, again, you see there is really no difference. But if you look at the hip, it's about 2.9. There is a slight advantage on the total hip. I think this looks better with the extension data that came in. So in the first 12 months, they didn't find anything, but they continued this for another 94 postmenopausal women. Yeah. So this graph, I think, explains it. The dark blue is the combination. The red is the teriparatide, and the purple is the denosumab. So over the after 12 months, you see the difference coming up. Lumbar spine at the radius. So actually with the teriparatide at the distal radius, there was no increase. At the femoral neck and at the total hip. So although at the end of 12 months, there was not much difference in the combination versus individual, when they were followed up for the 24-month period, the advantage was very clear. And that is why now there is a recommend. I mean, it's not a standard thing. You could go one after the other as, you were mentioning it. But if you have a elderly person, 75, 8, I said 72, this could be 85. My friend's mother is 95. 6 months ago, she had a fracture neck femur. She would be an ideal patient, to use this combination from the beginning. See, the problem is not the doctor prescribing it. The problem is when you say an injection to be taken every day for the next 2 years, uh, most patients, the elderly, are reluctant, and especially if they are staying alone, no support of the children, it becomes very difficult. So then it becomes, one side is science and the other side is your social responsibility sort of thing. And if they're not going to take treatment, then it is better to go for the second best treatment, which is probably once in 6 months denosumab or once in a year zoledronic acid. Because with both the drugs, in terms of fracture hip reduction, is nearly about 50% or so, 40 to 50%. So that's what I wanted to bring out today. Whether you are using the combination therapy from the beginning or you want to go one after the other. But remember, if you're going to use teriparatide for 2 years, you have to follow it with an anti-disruptive therapy. And similarly, if you're going to use denosumab between 5 and 10 years, you have to follow it up with zoledronic acid to cement whatever has been gained. That's the important take home, that you can't end your treatment with either of these two. It has to continue then with a bisphosphonate.
Now, would you prefer either denosumab or bisphosphonate?
Okay, so in the first 3 to 4 years of therapy, whether you're using bisphosphonate, and although personally I prefer to use zoledronic acid because of compliance issue, if someone says I want to use the oral alendronate versus the intravenous zoledronic acid, I will see that the patient is compliant. Then the results are nearly the same if the compliance is nearly the same. So you could use bisphosphonate. But after 3 years of treatment, if you follow these patients up, the patients who are treated with denosumab continue to increase their bone density 6%, 9%, 12%. Whereas patients who've been treated with bisphosphonates, they tend to plateau off between 4, 5, 6%.
So can we infer that denosumab is a preferred molecule than zoledronic acid?
So if you're going to think of a long-term treatment, like here, obviously, then my preference would be to use denosumab because of long-term gains. In the first 3-4 years, you may not see the difference.
You mentioned about the combination therapy with denosumab and teriparatide. There was a Japanese study also on a similar line.
Yeah.
They had published in 2017, and they had shown a very promising results with that. In fact, one of the company was recommending that you can start immediately after that. And well, I have not yet tried, but we will now after your talk. We'll
at least think about it. You don't have to run into it tomorrow. Do what you're doing every day, but think about this and maybe look at the options. I'm not, because this is not a sponsored talk. It's pure science, so we can discuss whatever we want.
And main thing, see, like a treatment naive patient, that is where is the problems are. They are the ones where we have to decide the whole line of treatment, start from A to Z. So that's where I think denosumab, if we say, some of them are discouraged because the cost factor comes into play, though it is once in a year. Zoledronic acid.
Yeah, zoledronic has become cheap. When it started,
it has become very cheap. It has become
it was 19,000.
So they have their issues with the costing.
So cost is always an issue in Indian practice. But if you talk to, let me tell you, I mean, endocrinologists always have this problem about cost of therapy. But I've never seen a cardiology patient complaining of cost, whereas their drugs are 10 times more costly than what we write.
Sir, इधर लगता है तो मर जाता है ना सर.
So that's what
हड्डी से कोई मरता नहीं है ना सर.
नहीं, but that's what I tell them. Baba, if you land up with one of my orthopedic colleagues, 2.5-3 लाख रुपए ऐसे ही खर्चा होने वाला है. So then,
Manoj, I think this is little
below the belt, below the belt.
okay, I'll take it back. No, never meant to hurt anyone, but I do explain that they have to prevent a fracture.
No, just joking, just joking.
No.
Somebody
Okay. Yeah, please, Dr.
lighten the mood, just to lighten the mood.
Yeah.
A friend of mine who is very, very witty, he says that these days all orthopedic patients walk off the table. They come home in cars and go home walking.
Yeah. Yes. So
सर उसका नाम दे दो, मैं जाके सीख के आता हूँ थोड़ा कुछ सर.
That is just to
but
lighten the mood.
I have seen now when you all are doing knee replacement, by evening the patient is walking and 72 hours patient is ready to go home.
Correct. Why 72? 72. There are people who send next day.
Next 48 hours. Okay. I mean, that's fantastic.
Yeah. Tremendous improvement.
Okay. So now this is what I was trying to bring up. Again, this is food for thought. You don't have to start getting into it right away. But when you see diabetic patients, then the T-score, even if it is less than, more than -2.5, -2, -2.2, or -1.5 also, please look at it seriously. You may need to take action. In contrast, in a non-diabetic, this one okay. Has this come up again? Yeah. So what we said that we will wait for 6 months, correct the vitamin D and call the patient back. Now, in the past, we used to say that osteopenia should not be treated with bisphosphonate. What we are talking of prevention of osteoporosis. But couple of months ago, to be precise, 2018 NEJM publication. So Ian Reid is one of the biggest BAP in bisphosphonate, especially in zoledronic acid from New Zealand. And what he did was he took 190 women in placebo group and 122 women in the zoledronic group, 65-year plus ladies with osteopenia, and gave them zoledronic acid once in 18 months. And that was, I think, for three shots. The fracture risk was reduced in zoledronic acid. And the important thing is you need to treat to prevent one fracture, you only need to treat 15 women. So it was really, in terms of the benefit that came out of therapy, was really fantastic. So the placebo, in compared to placebo group, the zoledronic acid treated patients had a 37% risk reduction. And like it said, you treat one woman, 15 women, you can prevent one fracture. So now this is something which we have to start looking at in practice, whether we want to apply it in our day-to-day practice. Once in 18 months, zoledronic acid. So that's
what was the age of these patients? How do you define elderly?
65 plus.
Achha, 65 plus. Okay.
Yeah, I mean, it's not there in this whole discussion, but if someone wants to note this down, NEJM 2018, this is a study is very interesting. So this decrease in height of the aging population, X-ray spine showing collapsed vertebrae, whether you have a T-score or not, I think this patient needs to go in for therapy. Again, we could have an argument that whether we should give zoledronic acid, denosumab, or teriparatide. Here, probably, you have to decide. This is, I would say, comparatively a younger patient who's going to live much longer. So what we would use earlier is an anti-resorptive and then keep the teriparatide for a rainy day. The counter argument is use teriparatide right today, get her into good shape, cover it up with anti-resorptive later on so that she doesn't get a rainy day. So, it's your decision at the end of the day how you would like to continue with the management of this patient. If you find that there is a T12 collapse and there is another L2 or L3 collapse, then immediately go for teriparatide. But if it's one vertebral collapse, a T-score of -3, -3.5, you could wait. But if you get a T-score of -4.5 or so, which is pretty bad, then I would not wait. I would straight away start teriparatide. I think most corporate hospitals get such patients. Young patient, 38 years, routine health checkup, backache and things like that. Vitamin D is low, T scores are minus 2.6. I have seen these patients getting not one bisphosphonate, but two different bisphosphonates, a short acting one and a long acting one. And it is beyond my comprehension why this patient should get forget two bisphosphonates. I don't know what is your experience with this, but this is something which really upsets me, when I see my colleagues writing that. So in the first place, in the first place, a young lady should not have a BMD.
Correct.
Not that it is going to harm her or anything, but actually it harms her in this way, that they end up on drugs which they should not be on. So that's, I think, one of the important messages, that don't rush into treatment just because you saw a report. Try to understand what is the reason for that. Okay, so I think at the end of my last one or two slides, this is a summary which I have been talking again and again. So you need to see the effect of the drug at the vertebra, at the hip, and the non-vertebral fracture. And most drugs that we have, alendronate, zoledronic acid, denosumab, teriparatide, when it comes to the non-vertebral fractures, they're not that effective. They are, you're looking at about 30%, 40% risk reduction. At the vertebral, it's the best, 70 to 80%. And at the hip, it's again 40, 50% or so. And raloxifene, I mentioned, really doesn't have effect beyond the vertebral column. And we didn't discuss or talk about calcitonin, because calcitonin is no longer considered an anti-osteoporosis therapy. It's an expensive analgesic therapy which you can use for 15 to 20 days in your patients for painful fractures. Teriparatide, initially I used to put a cross at the hip, but now with the data coming in, it also has good effect at the hip. And I'm going to stop at this with the, the gaps that are there in our therapy, but things are improving. For me, what is important is to get sensitized the different players in osteoporosis management. So whether it's starting with the orthopedic surgeons, the endocrinologists, rheumatologists, gynecologists are an equal important part. They have to get involved and they have to think that osteoporosis is a serious disorder. What I say is that it is one of the very few preventable disorders. And as I showed in the first lecture, my slide on peak bone mass, if you want to prevent osteoporosis, you need to start as early as possible, preferably from the mother's womb. And then when you have not succeeded in that, then you've got a couple of therapies, starting from the non-pharmacological therapies and now good pharmacological therapies also, but they have to be used properly and they have to be used for the required period, and keep a lookout for their side effects. They are there, but fortunately they are small, the serious side effects. This tolerance issue and all that can be sorted out. There are patients who are fussy. There are patients who actually get problems. So you need to change your therapy. But overall, I think the future for osteoporosis, especially in the next, 12 months, there are 2 new drugs coming out. It's very exciting for the bone formation, for the anabolic therapy. I'll just mention those names and a little data on that next time. I think I'll stop at this time. I think we've gone over the 1 hour, but if there are any questions, I'll still take them.
Yeah. Were you going to mention about the abaloparatide?
Next time. Romosozumab, abaloparatide. Yeah. We'll discuss that, but very sparingly. I'm not going to go into too much detail.
Is romosozumab? It sounds like a tocilizumab.
Yes, it is. It's a mAb, no?
It's a mAb.
So denosumab, romosozumab, these are all MABs.
Okay.
So this is an
RNA derivative.
Yeah. So these are anti-sclerostin antibodies. So if you want, I can show you some interesting cartoons. Otherwise, I'll just tell you how they work. That's your choice.
Are there any questions from the delegates?
Yes.
Before we ask
so
questions?
there are 2-3 questions. One question is that you told about the ideal treatment is denosumab plus teriparatide. And there is a compliance issue and there is a cost issue. So what is the next best thing? Zoledronic acid or alendronate?
So the next best thing is between using denosumab alone. Then you have zoledronic acid. And personally, again, I said it's a personal thing. It's nothing to do with efficacy, but it's to do with compliance issue. Then alendronate comes in the last. I can tell you at the same time, there are patients who will not take parenteral therapy and they want to take only oral therapy. So as a rule, I give all the options to my patients and let them take a call.
So there was this brand name sent to us in a form of screenshot, which had calcium anhydrous 1250 milligram. It also had methylcobalamin and everything. I think basically it is an irrational combination. That is what I would suggest. And so there were two questions which were unanswered from last time. How long maintenance dose of vitamin D to be given? Is it lifelong?
You already answered.
I answered that. Till such time that Sarkar starts giving fortified food, you have to give supplements.
Right. So how long the calcium should be given, age-wise demarcation? Should there be a holiday gap while giving calcium?
So if you're giving all in all, that means dietary calcium and supplementary calcium amounting to about 800 milligrams to 1000 milligrams. So I said the lower figure because if you're vitamin D deplete, then you don't need 1000 milligrams. If you're, we used to be vitamin D deficient earlier, so we needed 1200 milligrams. So if you can keep your total calcium intake to less than 800 milligrams, you don't need to worry about holidays. But if there are issues about patient following up, patient not taking or patient taking more, you can give your prescription in such a way that, you know, in 3 months you take it for say 10 weeks and give a 2-week break. You don't need to give week on, week off like that. No, that will not work. But somewhere in 3 months, if you give week 10 days off, it's acceptable.
But if they are taking, say, low dose of calcium or the recommended dose of calcium post osteoporosis, means after the age of 60, 70, so 500 milligram or 1000 milligram, they have to take every day.
You don't need to stop it. There is no reason.
Okay.
There was a big study from cardiologists that calcium given regularly is likely to cause more incidence of myocardial infarcts.
Heart attacks.
How far it is?
So these studies from the same group from New Zealand, which I showed you, Ian Reid and Mark Boland. So that comes from a country, New Zealand, which is full of milk and cheese. And then there was some publications from European countries where again they're full of milk and cheese. So let's say that if your country has high in milk and cheese and you're taking a lot of calcium in your diet, please don't take calcium supplements, which we all agree. We have been saying, if you can take it, but the Indian studies have shown that our average dietary intake of calcium is 250 milligrams. So we are far away from getting into this.
Yeah, you need to be a Dhoni to be calcium sufficient. He used to drink 3 liters of milk every day.
Yeah, so I said 1 liter of milk will give you 1000 milligrams of elemental calcium. So we'll meet next Tuesday, and probably if there are some more questions which you want me to prepare earlier, you can send it to me, or we'll take it up next time. And if Dr. Agashe or Dr. Gandhi wants to put in some cases,
Sure.
We can.
So we had discussed, sir, that next week we'll be talking about the fracture liaison service, and you needed one orthopedic surgeon. That is why Dr. Agashe. I had hoped that he will recover and he'll be back in time for that.
I was thrilled when he sent me a message in the morning. It's great to have you back.
नीरज मैं भी ऑर्थोपेडिक सर्जन है यार, तो क्या
अभी हो?
अरे तो आप
सर है वो अलग बात है यार, सर है लेकिन ये तो अपने को ऐसा डिस्काउंट मत कर।
हमारे लिए डॉक्टर आगाशे इज द मेंटर।
नहीं
for all of us
डिस्काउंट नहीं किया आपको। Only thing is they are thrilled that I am back.
Yes sir, we are definitely thrilled sir, definitely sir.
That's
okay, thank you.
There will be what will be the exact topic next year, so we can announce it for the people who are already watching.
Teriparatide पूरा बाकी है तेरा, teriparatide and newer
discuss in a day or two and then come back.
I mean, we can just call it simple as fracture, importance of fracture liaison service, how to prevent a second fracture, or like the IOF says, catch the fracture, something. I mean, we can put something catchy there. I'll send you a WhatsApp.
And we will show some cases, all of us.
Yes.
Dr. Gandhi, aap bhi do at least 1 or 2 cases, whatever you have.
Done.
So we can prepare.
Yeah,
I have actually got a case today. If he gets operated, then I will show it to you. He's a young osteoporotic, 44-year-old, but he's got 2 fractures, distal radius and IT both together in one fall.
So I hope you looked at his testosterone.
Yeah, I'll just that is a good idea.
So see, in a young male, you have to have a reason.
And
And
the
like-
relative was telling me that he generally feels very weak after his job. He goes to the job every day, but he generally feels very weak.
So if a male feels weak, you please look into the whole story.
Okay.
Diabetes.
Sir, and something, if you can mention about the NICE guidelines
Okay.
next time.
I've got.
So, yeah, it will be better, because a lot of people are not aware, though we are not following that. It's very difficult to follow the guidelines. But
ठीक.
NICE guidelines, जरा हो जाएगा.
Okay.
करेंगे.
Okay.
Okay.
Thank you very much.
Okay,
Thank you,
thank you,
Dr.
sir.
Manoj Chadha, sir.
Bye,
Thank you,
everybody.
Dr. Akash ji. Thank you, Dr.
Bye,
Gandhi,
bye,
sir.
sir. Akash
Yeah,
sir, thank you,
see you
sir.
next